So next speaker is Professor Paolo Decuzzi. Is he here?
Hello. I can actually see the presentation and myself also in the picture. Good morning, everybody. Paolo Decuzzi, and thank you for the brief introduction. I'm very sorry that I can't be there today in person. I've received multiple pictures from the last few days in Basel from friends and colleagues that I've been meeting many times at Cleaning over the last 10 plus years. And so I feel really very sad that I cannot be there in person, but I'm at the same time, I'm happy to see that you're enjoying scientifically and also non-scientifically the event in Basel. So today, in the next 10 minutes and so, I'm going to be presenting one of the technologies that we have been more recently developing in our laboratory in Genova at the Italian Institute of Technology, which is focusing on a technology platform for the treatment of brain disease, and in particular brain tumor, and the most aggressive of the tumors, glioblastoma. And I'm going to be sharing with you this first slide that actually somehow summarizes very quickly what we already know and we have been knowing for some time about aggressive brain tumors. Beside the data and the title from the Wall Street Journal, and you can clearly see that for many cancer, we have had significant improvements over the last 30 years, but there are cancers, and previous speakers, they have been talking about pancreatic cancer, liver cancers in the previous day in Basel, but glioblastoma is clearly one of the cancers where the success rate has been so very poor so far, and we have a 5-year survival, which is about 5%. And even more striking is the fact that if we look at what has happened over the last 4 decades or 2 decades in terms of improvement in incidence and mortality associated with the disease, the curves are pretty much flat. As scientists, we know that when a curve is flat, nothing has really happened. And this is for a number of reasons. There are, of course, biological barriers that need to be overcome, like the blood-brain barrier. There is a tumor heterogeneity, a biological heterogeneity that is characteristics of these aggressive brain tumors. There is a tumor microenvironment that tends to be immunosuppressive as compared to other tumors. And so even immunotherapies, they're not really working nicely in this context. And then there are also barriers associated to the translatability of the research that is conducted on glioblastoma and brain tumors due to their limited number of patients, and so investments that are a little bit scarce. Anyway, beside all these barriers, one of the approaches that we have been proposing that we've been developing for attacking this disease is based on the development of these multi-compartmentalized biodegradable and polymer-based system, which we call micromesh. Here you see a cartoon on the left-hand side of this micromesh that is deposited over a complex network of cells. You see neurons, you see astrocytes, you see microglia, you see infiltrating monocytes and macrophages coming from the peripheral circulation. So a complex network of cells that communicate, they connect to each other, and actually fuel the development of the neoplastic disease. And then on the right-hand side, you see images, fluorescence and electron microscopy images of 2 of the major compartments in the micromesh. This network of very regular PLGA filaments, which is called a PLGA micronetwork, it's the compartment where we load, and we tend to load hydrophobic molecules. And then we have a microlayer called the PVA microlayer because it's made out of PVA, where we actually load hydrophilic agents. And this could be nanoparticles, antibodies, peptides, enzymes, as well as I said, nanoparticles of different type, liposomes and lipid nanoparticles, polymeric nanoparticles, and so on. So with these 2 compartments, you can really deliver a very complex therapy to the brain parenchyma and directly to the brain tumor. These are additional details of the micromesh. You see the fine network and structure of these filaments. You should notice also the size, 5 microns by 3 microns, with opening of the order of 20 microns. This makes these systems very tiny. So these PLGA filaments are really very tiny, much smaller than one of our hairs, and so it's very deformable. And you can see that the mesh, when it's deposited over the hemispheres of a brain of a mouse, they actually conform nicely to the surface, and you can see through them because, of course, of the openings and materials that we are using. You can also appreciate in the movie down here how flexible is the system, and the fact that we can actually have a micromesh that is originally fully folded, and once it is deposited in a biological solution, it tends to open up, spread around, and actually take the configuration of the complex geometry that is actually surrounding the micromesh. So it's not a gel, but can be actually deposited through catheters, can be positioned through catheters because it's very tiny and can actually be deformed and folded, and tends to open up and take up the shape of the surrounding environment. So it's actually conforming to the complex tumor microenvironment surface. We can microfabricate it in different sizes and shapes. The size and shape of these micromesh can actually affect the delivery as well as the biodegradation and the therapeutic efficacy, of course. And we are studying that systematically. Currently, the 20 by 20 micron is actually the mesh that we're using more extensively also in animal characterization. As I said, you have 2 compartments, an hydrophobic and hydrophilic compartment, and this comes with a great opportunity, that of releasing not only hydrophobic and hydrophilic molecules, but also modulating the release rate the way you want. And so you can go from things that are released over the course of tens of hours, a few days, to agents that can be released in a sustained manner over the course of several weeks, up to actually a few months, sustainedly intracranially. This is very different from, for instance, system like Gliadel that had been developed 20 years ago, where there was one single molecule that was delivered, and it was delivered over the course of a few days. So here you can really realize a combination of therapeutic and immunostimulating agent together, and they can be released in a sustained manner for a significantly long period of time. As I said, one of the features of this micromesh is the ability to conform and adapt to the complex biological surfaces. You can see here an electron microscopy and a confocal fluorescent microscopy of a micromesh that is actually wrapping around the tumor spheroid. And this wrapping, this mechanical conformation, is not only a fancy engineering thing, it actually comes with some therapeutic implications, because if you look at the growth of this tumor spheroid, which is made out of glioblastoma cells, U87 and G cells, if the tumor is untreated, the spheroid is untreated, you basically have an unbounded and continuous growth of the tumor mass. If you treat them with a micromesh, you basically, at this specific and particular concentration of docetaxel, you have a flat plateau, no growth, no decrease. But if you treat it with a flat micromesh, whereby flat micromesh, we mean a mesh that doesn't have these holes, so it's flat and cannot deform and conform, then you do have some level of treatment because you're releasing docetaxel, but it's not as effective as the actual micromesh that is conforming around the spheroid. So this mechanical conformation has some interesting implication. We also notice that when we release agents like nanoparticles from the micromesh, they actually travel deeper into the tumor tissue. And you can really appreciate that by looking at fluorescent distribution within a tumor spheroid that is being exposed to nanoparticles released from the micromesh with micromesh, or just incubated with a spheroid. So the same nanoparticle, same size, same surface potential, zeta potential, same properties, they actually penetrate much deeper when they are released from the micromesh. And we believe that is associated also with the formation of a nanoscopic thin layer over the surface of the particle in this specific configuration made by PVA that actually create a sort of a lubrication at the interface with the tissue and facilitate the deeper penetration of these particles into the tumor parenchyma. Now, Having presented all these different features about micromesh, you know, of course, once you're done with all the in vitro characterizations, then you need to demonstrate what is happening in vivo. And we've been developing different orthotopic tumor models, both with xenografts, U87MG, cancer stem cells from patients, as well as syngeneic models using mouse cells, CT2A, into mice. And so basically, the ideal system for studying the response to immunochemotherapeutic approaches in immunocompetent mice. And also what we have been doing is somehow mimicking what a neurosurgeon would do. So we, in some cases, did not remove the tumor mass. And in other cases, we did exactly what the neurosurgeon would do after opening the skull, removing as much as possible without compromising the quality of life of the patients. And so you will see data regarding tumor removal and non-tumor removal, or resected tumor and unresected tumor. The first configuration of the micromesh that we put out and we published a couple of years ago was actually coming with docetaxel nanoparticles distributed within the PVA microlayer and a potent anti-inflammatory molecule called the diclofenac, that was actually distributed within the green grid of PLGA micronetwork. So this was the configuration with a concentration of the drug in the order of, with a loading of the drug in the order of 0.75 mg per kg, locally dispersed. So the micromesh, after generating the hole in the skull, was positioned either over the tumor mass or over the resected tumor mass. And then we would follow using bioluminescence the progression of the disease, and at the same time, of course, generating Kaplan-Meier survival curves for the study in essence. Now, here you see two different plots, two different survival curves, one in the case of no tumor removal and the other one in the case of tumor removal. Here, remember, you have nanodocetaxel, so the nanoparticles loaded with docetaxel in the PVA microlayer, and you have diclofenac in the PLGA micronetwork. Now, if you do not remove the tumor, eventually 90% of the animals, 9 out of 10 animals, will die. But you see that the line that associated with the micromesh is outperforming all the others, and there is a significant increase in survival. However, if you do what any neurosurgeon would do, which is removing partially the tumor mass, you will see that at this point, 90% of the animals will survive, and only 1 animal out of 10 was actually lost around 100 and something days. One thing that is important to look in this plot is the control curve. The control curve is the curve where you do remove the tumor mass, but you don't treat the disease. So the animal is left without any treatment at all. And you would see that it's still dying. So yes, we are removing the tumor mass. So yes, we are reducing the tumor burden on the animal, but eventually the tumor, these are U87MG cells, will grow back, and the margins will grow back and will dictate the death of the animal. Something that you don't see when you use the micromesh, something that you see less when you use temozolomide, which we know is working because it's the gold standard in the clinic. And the other thing that I would like to emphasize is that the micromesh is loaded with these nanomedicines carrying nanoparticles. But the difference between the carrying docetaxel, the difference between this yellow line and the green line is that in the green line, the micromesh, these nanoparticles are released directly from the micromesh. In the yellow line, they are injected intratumorally 1 time. And so with the micromesh, we have the increased deep penetration of the particles. We have a more uniform distribution of the particles within the tumor parenchyma, and this automatically reflects in an improvement in therapeutic efficacy. Now, this was 2021. We published another paper. Actually, it's not coming soon, but it's actually been published a few weeks ago in ACS Nano 2023, where we did another experiment. So what we did is we treated the animals either with docetaxel or paclitaxel in the green network, or with nanodocetaxel and nanopaclitaxel in the PVA microlayer. So either one or the other, either docetaxel or paclitaxel, either nano or molecular. with a major difference that the nanodocetaxel and nanopaclitaxel were released over the course of a few weeks, whereas the molecular docetaxel and paclitaxel were released over the course of several weeks to a couple of months. And you see that, first of all, the system has been potentiated as compared to the 2021 data, and you see that there is a significant increase in survival. But also, you see that basically the docetaxel alone micromesh that can guarantee the release of docetaxel for several weeks, at least for a couple of months, then you can have a significant improvement in survival over all the other configurations. And this again somehow is demonstrating that if you can realize a system where you can deliver a potent chemotherapeutic agent locally, you can actually control and modulate the progression of the disease and the margins of the tumor. In this case, notice also that we are not removing the tumor. So this is on the full tumor. The last slide, these are very new data not published. Of course, we've been looking also at this point at immunochemotherapy. So the same animal model with the orthotopic tumor, but in this case, we are implanting locally CT2A cells. So this is a syngeneic mouse model where the animal is immunocompetent. And we are using docetaxel as the chemotherapeutic agent that is distributed within the PLGA network, and ACD47, an antibody for the immune checkpoint CD47, which is loaded in the PVA micro layer. Now, the first thing that you can see in this plot is that, well, the animals die much faster than with the U87MG. This is a very aggressive syngeneic model, very metastatic in the brain, in the surrounding of the brain, as opposed to the U87MG. So it's a way more aggressive. So you see that it's actually the animals are dying at least 10 days, 15 days previous as compared to the U87MG cells. But if you do use the ACD47 into the micromesh, as opposed to the multiple injections of the ACD47 intraperitoneally, you see already a small but significant improvement in survival. Even more when you actually combine docetaxel with ACD47 in this more extensive study, you can actually see that there is a duplication, at least in the survival of the animal, with these very limited doses of compounds that we have been using. We're continuing working on this immunotherapy. We hope that we can actually push even farther the survival by doing one simple thing, increasing the dose. 0.75 mg per kg and 1.25 mg per kg of taxane and ACD47 is well below the tolerability of the animal. And so we're going to be now looking at increasing by 2 and 5 times. And we are already running these experiments and see if this brown curve can actually be moved much higher than what it is right now, and so push even more the survival. With this, I would like to thank you. I hope I have conveyed the message that the micromesh with a sustained release of different agents can actually be useful in treating the margins of glioblastoma. This is a relatively recent picture of the group. It is October 2022, so about 1 year ago when we had the first conference in person in Genova for the Control Release Society. And you can see some of the major players in the micromesh team. And these are Daniele Di Mascolo here, Annalisa Palange, Cristiano Pesce here, and then we have Irene Guerriero here. And with this, I thank you very much. I'm again sorry that I couldn't be there in person. If you want to pose questions to me, please feel free to email me directly, paolo.decuzzi@iit.it, and I will be more than happy to respond immediately. Thank you.